Right. We have our next two presenters up now. We have Dr. Tietz and Dr. Archer. Dr. Tietz is an assistant professor at the Icahn School of Medicine in the Department of Family Medicine and Community Health. He practices integrative family medicine in a federally qualified health center and is the founder of Integrative Wellness NYC, a private integrative medicine practice in Manhattan. He is also an educator and researcher and is the director of the Integrative Medicine Fellowship at the Institute for Family Health, affiliated with the Icahn School of Medicine at Mount Sinai. His research is focused on integrative health and the underserved context with studies in acupuncture and yoga. He also has an interest in larger philosophical questions about the practice of medicine. And then we also have Dr. Archer. He completed his residency training in family medicine at the University of Rochester with a focus on providing biopsychosocial care for underserved and marginalized communities of color in the city. He then completed a 2-year LEAP fellowship, which is a Learn, Educate, Advocate, and Promote fellowship in palliative care at the Mount Sinai Medical Center. During his second year of fellowship, he focused on alternative and integrative strategies for addressing psychological and existential distress and serious illness, particularly in psychedelic medicine and contemplative medicine. He is now an attending physician at the Brookdale Department of Geriatrics and Palliative Medicine, Mount Sinai, where he practices outpatient palliative medicine with the goal to implement these practices in group settings to address psychological and existential suffering and facilitate healing, particularly for communities of color. Thank you guys so much.
All right. Thanks so much for the introduction. Thumbs up. You can hear me okay, yeah? Okay, good. So we're going to look at integrative medicine and geri and palliative medicine. We're going to tag team for you. The objectives today is our hope that you as the audience will become familiar with an integrative medicine approach in geriatrics and palliative care, a wellness approach in cancer, evidence for non-pharm modalities for acute and chronic pain, some dietary supplements with common geriatric conditions, and then a wellness approach to frailty. Your speakers, really, we've been introduced, I think. I'm at Sinai in the family medicine department, and Dr. Archer is in the geriatrics department at Sinai. And you've heard predictably the rest for us. I will be mentioning some brands of supplements. There's no conflict of interest. I don't have any financial interest in any supplements at all. But as you'll hear a little bit with dietary supplements, it's often good to be as concrete and specific as possible. They're not endorsements as much as identifying guidance there. All right. I'm going to give this to Dr. Archer to introduce the patient case.
Yeah, so this is a case I actually saw a very similar case last week, but you'll have a 55-year-old patient come in with metastatic breast cancer, admitted to the hospital, to the family medicine service. It's a new diagnosis. The prognosis is poor, but chemotherapy is still an option. The patient has capacity, is very close to their family, wife and 2 kids, one of whom is a physician. You have a family meeting where you'll discuss goals of care, talk about how the family is open to different types of therapies, wants to try everything, and their goal is really to preserve quality of life while fighting cancer. And this is something that's very familiar. The question that you might receive from a family member, the question that I got from a family member last week, what can mom, dad, sibling do to help herself be as strong as possible to fight the cancer? And we're going to spend a little time talking about today.
And so we wanted to call this last question out a little because I think most of us are familiar with palliative approach to cancer and certainly chemotherapy and the idea of going after the cancer in a more active way. Arguably, what the family was asking, or a way to understand it in its most robust form, is a wellness question, is the question with wellness. How do we help our mother as a person? How do we help our loved one as a person be as strong as possible, as well as possible, in, of course, the face of a probably terminal diagnosis? So I want to highlight, as we move through these slides, a lot of what we're going to be talking about will fit in the typical paradigm of disease indication and evidence, et cetera. But we did want to acknowledge this wellness piece to it, because we will use this term and we will talk about some wellness approaches. And then our challenges. I think the biggest is just we're moving, in a sense, out of the disease paradigm. We're moving into a different one. And that can be challenging, number one, with this whole concept of food as medicine, right? Sounds nice, and it is important, but it does mean that it's harder to evaluate it in the way that we would think with the typical lines of evidence. The second is, I just want to acknowledge, boy, if there's anything that maybe has more play in the market, other than RFK, is the idea of wellness. So it has a lot of entrepreneurial and market baggage that I think sometimes makes it a little hard to hear or a little hard to work with sometimes. And so I just acknowledging that what we'll do is ground it as best we can. A lot of the modalities we think about in the wellness setting, like acupuncture can be in a wellness context, dietary supplements can do that. Some of them don't fit into the standard pharmaceutical research model, specifically acupuncture and mindfulness, let's say. So that also is a challenge. And then the last one is that the modalities themselves and the paradigm itself can feel different to patients and providers. I've offered yoga, for instance, to an elderly woman some years ago. And the answer I got back from the woman's daughter, who did help her make her decisions on her health, was that, well, no, my mother can't do yoga. She's Christian. And so, and I get it. I mean, that's not how I understand yoga. And ultimately, we're not going to push through that. But it was a recognition that these modalities can feel different to different folks, and that has to be unpacked. So that's just wanted to highlight that as some of the challenges as you think about what we're talking about today. You can see here this next slide, which I'll just comment, really my approach is more the integrative medicine side, and I'll let Dr. Archer continue talking about the whole picture.
Yeah. And kind of to the purpose of this slide, really, we're talking about a different approach. We're talking about a wellness approach. We're talking about an integrative medicine approach. And yet, at the same time, one of the things that attracts me to integrative medicine, in addition to palliative medicine, is how much overlap and how much synergy these two things do. And so what I'm listing here is the things that I think are really similar between the palliative medicine approach and the integrative medicine approach. They're both whole person centered. They're both evidence-based to the degree that they can be, notwithstanding the challenges that Ray posed and notwithstanding some of the challenges that we have in palliative medicine with limited studies and data and kind of us trying to do the best that we can to provide the best care that we can for our patients. In both situations, patient goals and preferences are elicited and prioritized. So like Ray was saying as well, if someone has a hesitancy around a certain modality or certain therapy on both sides, we're really taking that into account and also trying to honor the things that are really important to them. So coming back to that question of what can we do to strengthen our family member or strengthen myself in the face of this illness? Both really have a strong psychospiritual care focus and are really looking at things beyond just the physical, just the biological. And here, I think a place where there might be a difference to explore more, and we're going to get more into that as we go into the talk. Palliative medicine really places an emphasis on, total pain, addressing suffering, whereas the integrative medicine approach is really one that's focused on health, well-being, and lifestyle approaches. And that's a place where we'll see some difference. And we'll talk a little bit more about that shortly. I think it's also important here to kind of frame the discussion of wellness and frame the discussion of integrative medicine. This is one type of whole person assessment. This is specifically from the VA hospital system. Many different integrative medicine groups will have their own system in which they think about an individual person, their community, their surroundings, and all of the different things that go into making that person healthy, contributing to their wellness and well-being. So in this one, again, from the VA, they divide things up and they have sections like recharge, which is looking at sleep and how people renew their energy. They're looking at relationships. They're looking at growing and connecting through the spiritual and soul and religious aspects of care. And again, there's a lot of similarities and a lot of overlap between the holistic perspective that we take in palliative care, just maybe in some places using different words and languages and focusing in slightly different ways. So food and drink, nourishing and fueling, that's something that I talk about a lot with patients when I'm talking about their nausea, I'm talking about their anorexia. And again, in the integrative side of things, we're really thinking about what are the foods that you're putting into your body? How are you eating things in order to make yourself as healthful as possible? And you'll see some of the other sections there. You want to go to the next slide, Ray? And so when we're looking at the integrative approach to cancer support, these are some of the things that I think it's really important to highlight, some of the things that I think about. I think about diet as being really primary, and we're going to talk a little bit more in detail about an anti-inflammatory diet and some of the evidence for that. Mind-body modalities are things that can help with quality of life, things that have some evidence for chemo-related nausea and other symptoms, as well as stress and anxiety. Acupuncture, we're going to talk a little bit more about in detail, managing symptoms like pain that has a surprisingly robust evidence base. Therapeutic massage and yoga as things that can be helpful for stress. And we'll touch very briefly on the judicious use of supplements in cancer support. So the anti-inflammatory diet is perhaps most popularized in the formulation of the Mediterranean diet. However, it can really be pan-cultural, and it's a focus on decreased inflammatory inputs into the diet. So if you look at the food pyramid that you have there, I'm sure that many of you have probably seen a version of this before, but with the inflammatory or the anti-inflammatory diet, we're really focusing on vegetables, fruits, whole grains, legumes, beans, and other kind of whole foods as the base of the diet. And as you work your way up, kind of minimizing things like animal products and using certain animal products that are less inflammatory, like fish and shellfish, whole soy foods as other sources of proteins, mushrooms as other sources of proteins, as well as eggs and cheeses used judiciously. And this slide I'll put up not to overwhelm folks, but really just we're talking about this idea of the inflammation and the way that it relates to health. And conversation about inflammation dates back for several decades, and there's a growing literature in a variety of disease states, including cancer. And there's some data in animal and cell models about chronic stress accelerating tumorigenesis. And there's also some human observational studies that are demonstrating that pro-inflammatory diets, the traditional American or Western diet, is associated with worse disease-free survival in specific cancers. And this is not surprising if we think about cancer as being an inflammatory state, as being a pro-inflammatory state. And if you are consuming things, if you are introducing large amounts of stress into your life, or kind of having large amounts of stress in your life because of our society, those are things that can worsen your cancer and worsen your overall health. This here is just referencing the SAD diet, the standard American diet, where much of folks' calories are coming from refined carbohydrates, fatty meals, processed foods, things that are really high in salt and sugar, and tends to be low on some of the things that we talked about in the anti-inflammatory diet, specifically omega-3 fatty acids, fibers, and micronutrients as well. Micronutrients here in contrast to macronutrients. You think about your proteins, your fats, your carbohydrates. Micronutrients are all the things that are coming from fruits and vegetables that are increasingly being stripped out of certain diets and contribute to anti-inflammatory processes. We've mentioned much of this already, but again, fruits and vegetables is foundational, whole grains and beans, preferencing certain sources of proteins like fish, soy, and beans, cooked varieties of mushrooms, and land animal meat at the top as being kind of the highest risk for inflammation would be the thing that you would want to consume least often. And what I tell folks with this is, if you're thinking about your body as a garden, you want to make it as inhospitable to the cancer as possible. And so these are things that you're doing to reduce the inflammation and make the cancer as unhappy as it can be inside of your body. This is kind of looking specifically, again, at certain micronutrients that can be very helpful and have some evidence for anti-inflammatory effects, specifically carotenoids that are found in carrots, cantaloupe, and other specific fruits, selenium, and quercetin as well. There's also some evidence for green tea, soy, garlic, and pomegranate, all as having some benefits, some anti-inflammatory impact that may be helpful. And additionally, it may be something that our patients can kind of take some agency in. Obviously, there are some patients that are really overwhelmed when they're starting their cancer journey, and I wouldn't want to add anything beyond the thing that they're already going through and all the appointments. But there are some patients who I find who are really motivated and really interested in saying, what are the things that I can do? What can I control? What are the things that I can do for myself to help myself as much as possible? And these are the populations that I would specifically talk to about this. Now, dietary supplements, specifically, there are certain varieties of mushrooms that some folks recommend for cancer treatment specifically, as well as antioxidants. And really our recommendation here is that given the stakes and the risk of potential interactions of dietary supplements with cancer therapy, it's best to discuss these supplements with oncologists prior to initiating them. And really the reason that we bring it up here is that it's important to talk to your patients about what supplements they're taking, because the vast majority of the American population has some exposure to supplements in their lives already. And it's important to talk about what they're using and bring that into kind of a team-based approach to their oncologist and potentially an integrative provider if you're finding yourself out of your depth. Now we're going to move into talking a little bit about chronic pain and highlighting the role that acupuncture can play in that. This is a patient, an 85-year-old male. He has high blood pressure, he has diabetes, and he has chronic low back pain that he's had for 12 years after a car accident. He is married. He had a recent x-ray that shows spondylolisthesis, and he's tried some of your usual interventions. He's tried physical therapy a few years ago. It maybe helped a little. He's taken some ibuprofen as well as some meds for his other chronic conditions. A1C is moderately well controlled, particularly for his age. He's not smoking. He denies alcohol and illicit drug use. And now we're going to touch on some of the guidelines for chronic low back pain. And these are guidelines that are a little bit dated at this point, but still useful. They're from the American College of Physicians and sponsored by the Agency for Healthcare Research and Quality, looking to provide guidelines based on effectiveness and safety, specifically for primary care. And in a systematic review, these are some of the modalities that they looked at in terms of their effect on pain and specifically their effect on function, as well as the level of evidence. And what is perhaps surprising to folks who are not familiar with the literature is that acupuncture, exercise, and MBSR are all towards the top in terms of their level of evidence, in terms of their effect on function and pain. Acupuncture kind of having the greatest impact actually on pain and effect on improving function for folks. Stronger than opioids, stronger than NSAIDs, stronger than duloxetine, which are kind of some of the first line things that we might reach for chronic pain.
Dr. Archer, would you just comment on MBSR in case people don't know the acronym?
Yeah, MBSR is mindfulness-based stress reduction. That is a specific kind of regimentized version of mindfulness therapy introduced by John Kabat-Zinn maybe about 40 or 50 years ago now, with a really robust research base in a variety of conditions and some evidence for improvement of pain, specifically in chronic low back pain. Ray, do you want to comment on this?
Only that, to your point, the American College of the ACP's guidelines that we just went through are dated. These are all the updates since, which has not changed that graph that they provided. Part of why I like using the ACP's publication is that they're a very not integrative organization, meaning that they don't have any particular biases toward one way or the other. And it was gratifying to see that's where they landed even in 2017. And these are the recent efforts to do more systematic analysis, which have confirmed essentially the same findings.
And then just touching on chronic pain more generally, there is evidence for some integrative therapies for other forms of chronic pain. Acupuncture specifically, again, probably has the most robust evidence base for a variety of different types of pain, from low back pain, neck pain, osteoarthritis, even headaches and migraines have some evidence for effectiveness. Therapeutic massage has been proven effective in cancer pain, neck pain, and chronic low back pain as well. There's some evidence for spinal manipulation therapy and MBSR and CBT as well, both cost-effective strategies for chronic pain and cancer pain. There's also mixed evidence, I would say, but definitely some evidence in terms of psychological benefit, in terms of stress and anxiety. That's where the evidence is strongest. And I just wanted to kind of pull out a specific recent meta-analysis looking at mindfulness-based interventions for chronic pain. This study from 2024 looked at 18 studies across over 800 patients and looked at the mean difference in pain scores. There was a small reduction in pain scores over the meta-analysis. And of course, with this meta-analysis, really, it's important to note the limitations. So MBSR is kind of the most regimentized formulation of mindfulness-based interventions, but there are a wide range of interventions, and there's really no clear definitive dose, which limits the ability to pull all of these studies together. And also, these studies are often with small sample sizes and limited long-term follow-up, and they face real-world challenges. There are lots of access issues, although there are some recent studies coming out demonstrating that telehealth can be an effective means of delivering some of these therapies. Overall, though, part of why I bring it up and part of why I'm a big fan of mindfulness-based interventions is that they're really low risk and there's a moderate potential for benefit across a wide variety of things, from pain to stress and anxiety as well. Acute pain was something that we wanted to mention too. There is some good evidence for the treatment of acute pain with acupuncture. This is also evidence for post-surgical pain in a variety of different integrative modalities, from massage therapy, MBSR, which we've talked about, music therapy, hypnosis, particularly for minor procedures, and guided imagery. Acupuncture has been used in the emergency department for pain in the low back, neck, and abdomen, and acute migraines. There are also some new FDA guidelines that are coming on acute low back pain management that may include some of these modalities as well.
Yeah, they do. The new FDA guidelines will include some integrative approaches as well, which is exciting. All right, and then to switch over to some thinking practically, I think it's not surprising that part of what we may reach for first when we look at that graph from the American College of Physicians is medicines is the access is so much easier. I mean, so it's to acknowledge that. And so some of the practicalities when we think about acupuncture is, number one, what's the dose of the treatment needed? This was actually a question that was posed by NCCIH, which is under NIH, the National Complementary Institute of Health, looking at, well, what should we do for elders 65 and up in terms of dose treatments? And that's what we did a study here at the Institute for Family Health. The second question is, who's the best to do it? Should it be licensed acupuncturists? In the state of New York, for instance, they have different amount of education than do MD or DOs to do acupuncture. They have more, 3,000 versus 300. It looks like, in terms of the studies, that probably anybody who can is certified or licensed to do the acupuncture is worth try in terms of chronic pain. And I would go back for a second to talk about the common number of treatments. I think if you have someone who has chronic pain, you would expect, kind of like physical therapy, that they would need 5, 6, maybe 10 treatments, usually done weekly. And so that wouldn't be unusual to hear that if someone sees an acupuncture. It can be shorter if it's more acute pain. The idea being is that there's less time needed to take. What's interesting is Medicare actually said, hey, we're going to have acupuncture needling as a benefit in our Medicare beneficiaries. They announced that in, I think it was 2020. However, licensed acupuncturists, which represent some of the heaviest access in at least the community of New York City, cannot bill Medicare. And so that's a barrier where only physicians can bill. And so how do you sort of sort that out? There are also, some private insurances are covering acupuncture, but it's like what we see sometimes with mental health, where yes, insurance will pay an acupuncturist money, but it's not enough to cover overhead. And so there's issues around that. And then sometimes you can patients can be seen in residency clinics or academic centers. In the same way, you can find academic centers. There's one in New York City called Pacific College of Health Sciences, where the students can provide lower cost treatments under supervision of their professors. It has a good safety profile, and there really are minimal contraindications. You don't really have to worry about bleeding risk, even with folks on Coumadin, et cetera, as long as they're not having, they're not super therapeutic or particularly bleeding. This is our recent study that we did where basically the N was originally 789. We actually got to 800, where it had 3 arms. We had a usual care, which stands as sort of a control, stands as the control. And then we had 2 arms, standard acupuncture versus enhanced, where they got more sessions. It didn't really look like over time that the enhanced sessions added a ton in terms of help around the pain, though maybe with functionality. And then you can see here, it was a multi-site trial here in New York City, and then on the West Coast, California and Washington. And we were one of the sites, and NIH was happy to have us because we had underserved. We were the only Medicaid population system. We had Spanish-speaking participants as well. And so we're in the dissemination phase now. In fact, through presumably an NIH announcement, it actually got a little bit of play 2 days ago on Good Morning America, where they summarized it, which was exciting, because this was, in a sense, NIH talking back to Medicare. And so this hopefully will have important ramifications and certainly validation for the Medicare benefit. All right, so let's switch over to supplements with focusing on the evidence. I mean, supplements are an arena where really they should fall in. They do fall in the same way we test pharmaceuticals, so should supplements. There's no reason we can't, as long as we know what we're doing in terms of whether it's a botanical from plants or whether it's something produced in a factory like CoQ10. So dietary supplements quickly does have a legal category and is ultimately under the auspices of FDA, but it's not regulated obviously nearly as tightly as pharmaceuticals. They're regulated mostly through the FTC around truth claims, where even though elderberry, which is a berry that when you cook it down does have evidence that it helps treat influenza, you cannot say that in any kind of advertising because that's only an FDA claim that you can make around diseases. And so instead, what you'll see for elderberry extract is it's good for immune support. Examples of dietary supplements are vitamins, and then things like coenzyme Q10, botanicals, which are from plants like St. John's wort, which we'll comment on. And then homeopathic medicines, if you're interested, actually are over the counter. They were grandmothered in many, many years ago in the 1900s. So to talk about St. John's wort, probably one of the most studied dietary supplements, botanicals, and it has decent evidence for the treatment of major depression, mild to moderate. In the same way, you could argue on par with the SSRIs and basically the other pharmaceuticals that have good evidence for mild to moderate major depression, which is in contrast to severe depression, where some literature suggests it needs to be more like tricyclics or even further therapies. There's been a lot of trials that looked at this. There was the last Cochrane review, I believe, was in 2008, and then there was a meta-analysis that confirmed again the same. The mechanism of action, not unlike many botanicals, is varied. It appears to have some effects on serotonergic, MAOI, GABA, glutamate. It doesn't appear to be an outright or overt MAOI, so there's certainly not the dietary concerns about it that you would have if you use those very old medications that are still around. And then what you see with botanicals sometimes is there needs to be a way to identify quality. There's all kinds of way to process things, right? There's all kinds of way in a kitchen to process, to make a meal. And there's also different ways to process botanicals, and then pharmaceuticals are processed arguably to the nth degree. So the typical extracts that you'll see for St. John's wort is something that's named WS5570, which is a standardized to these markers. These are not the active components. These are just markers of quality. And so that's where the evidence lies. When I think about dietary supplements, I'm interested in thinking about using them when they offer advantages over pharmaceuticals. Given that pharmaceuticals can be covered by insurance, given that we have a system of safety around it, it makes sense to me not necessarily to replace a pharmaceutical with a supplement that does the same thing, unless the patient really wants to do that. So the advantage of St. John wort arguably is it may have less side effects. It showed less dropout during the studies versus pharmaceuticals. It did have one head-to-head trial, for instance, with sertraline, and that's some of where they saw this as well. It does have some decent evidence in the specifically elder population, as Caspar pointed out. The ranges that you're thinking about is 500 to 1,200 milligrams. And here's a couple of good products. Nature's Way, for instance, has a good product and also has a price point that for many of our patients could still be affordable, 10 to 20 bucks per month, which might be the same as a copay. Consumerlab.com I'll mention, but just to say briefly as a way to evaluate different dietary supplements. This is the board question. It's worth knowing, and it is the biggest probably reason why I don't use St. John's wort a lot in the elder population, is because a lot of times they have polypharmacy necessarily, and so there's a lot. It is quite messy when it comes to its impact on cytochrome P450, specifically CYP3A4. And otherwise, it's pretty well tolerated. You wouldn't want to, generally, you don't give it with the SSRIs in case there's a theoretical risk of the serotonergic syndrome. You would start low and titrate up like you would with SSRIs. You can get some low-grade safe side effects. Maybe it's a weak photosensitizer. And so I think bottom line for St. John's wort, it's a viable option in terms of risk for elders and safety for elders with the caveat of pharmacy. If they don't have a large pharmaceutical burden, it's a reasonable thing to start with for folks if they're interested. We know more largely, if we're thinking about depression, that not so much in the elder population, but in general, from an integrative perspective, that exercise is going to be important. Now, we don't know exactly which type of exercise. As far as I know, this has not been updated, where we know that when they looked at this meta-analysis, it was aerobic and non-aerobic all lumped together. Some were on medication, some, and the effects were different. But nonetheless, the preponderance of the data suggests that exercise is helpful for depression. Mindfulness has some quality evidence as well. Anti-inflammatory diet might be helpful, again, some limited evidence, and then music therapy, dance therapy, or acupuncture, electroacupuncture. The way I think about this when I'm sitting in front of patients is if we're not talking about severe depression, if we're not talking about suicide risk, then we have a lot of space to sort of talk, well, what resonates with you? What do you sort of want to do next? And of course, none of these are exclusive. You can do multiple things. A second supplement that is, I think, more promising in elders in particular is lavender essential oil. So there's three essential oils that we can ingest as humans that's not toxic, and one of them is lavender. And so this is not aromatherapy. You can do aromatherapy with lavender, but this is actually taking it orally. And what we found is that it has anxiolytic properties. It can, and so initially, as we talk about this processing again, if you take, the flowers, you make the essential oil. If it's not in any way controlled, then it can have variability because the plants are going to be variable. So then what you do is you standardize it to get a standardized essential oil lavender extract where they look for these markers. So this is the same analogy to thinking about that St. John's wort, where you want a product that has these markers, 37% of one, 34% of the other. The mechanism for lavender oil, surprise, surprise, is varied, and it appears somewhat novel. It's not mediated by GABA in the way that, let's say, gabapentin is, or certainly the benzos. Not a ton of review and studies that I'd like to see more, but certainly the good news is it has been used for a long time in Germany because they regulate supplements actually under the same aegis as pharmaceuticals, so it's more present there, and has a good safety profile. I think the most compelling reason to consider it in patients is that it doesn't have dependence risk, and it also is not sedating. And so it's something to consider for folks. It might be as potent as paroxetine. You would do 80 milligrams twice a day of this standardized extract. This, again, is another Nature's Way product. Nature's Way originally was actually owned by a pharmaceutical company in Germany. So it was a company that was accustomed to all the regulations. I think it's owned by an American company now, but it has basically experience in doing a good job of making supplements. And so this is just to say that the safety profile looks okay, but it would be good to have more studies. And it might not work, I wouldn't think of Calmate as something that I would give to someone who's having a panic attack or the like, in the way that, the benzos can be so helpful. Ginkgo biloba, you may have heard of, also one of the most studied supplements out there. It does have evidence for benefit in dementia treatment, probably on par with the acetylcholinesterase inhibitors. The active ingredients in ginkgo are these ginkgolides, which have antioxidant, anti-apoptotic biological activities, and then also do have some effects on the various neurotransmitters. Here's Nature's Way again, no stock. They just do a decent job. It has a very good safety profile. It has a very large number of studies. And probably what you're looking at, again, you're looking at, number one, a specific extract called EGB716, which is what this is. And that's standardized to these particular ginkgo flavonoids. And you need probably 240 milligrams. We published on this some years ago. You can start, usually in this example, for instance, one serving size, which is how they label it, is 2 pills, and that's 120. But to actually get effect, you may need 240. And if you look at that, then it can be more pricey, up around $120. So for some folks, that's not doable. The one advantage of ginkgo that could maybe be helpful where you're not seeing as much effect from the acetylcholinesterase inhibitors is that it may be better in patients with neuropsych symptoms, the folks who have the agitation, the things that can get them, unfortunately, out of their home into a nursing home because people are concerned about safety. All right, to switch over to probiotics. Probiotics, again, lots of market entrepreneurial stuff. So to ground it, you're probably familiar. They are live organisms that when we administer them can confer benefit on health. They are bacteria or yeast. The way that probiotic gets studied is they typically pick a specific species. Lactobacillus genus, Bifidobacterium genus, and Saccharomyces boulardii, a yeast, are the most studied. And if you look, its biggest advantage and the way to think about how they can be helpful for our patient population, 65 and up, is for prevention of antibiotic-associated diarrhea. So they did, systematic review, 63 RCTs. This was from the HRQ, I'm pretty sure. And you can see a huge N. And it did have a relative risk reduction of 0.58 for antibiotic-associated diarrhea. The number needed to treat being quite small at 13. And you saw a second meta-analysis which found a similar relative risk and a similar number needed to treat. And let me jump here for a second. I need these slides different order. I lost it. And they've looked at harm, and the harm is really very minimal. And probably the biggest contraindication if you're in the hospital is not to give it to people with pancreatitis. There's some concern in that setting, it can be risky. But in the outpatient, there's really very few contraindications. Then there was this interesting meta-analysis found for prevention in the outpatient setting. Again, here to get specific is somewhere between 10 days to 2 months. And the specific strains they found beneficial, the Saccharomyces boulardii and something called Lactobacillus rhamnosus GG. The mechanisms, some of it probably is that they get in there and live there in a way, but there's also specific issues where they're going to have effects on bacterial adhesion, other bacterial to the epithelial cells sort of gets in the way, support of the epithelial barrier in the lumen as well, and then interaction immunologically. We know that if you look in the lab, you can see changes in IL-10 and 12. You can see reduction of pro-inflammatory cytokines. The probiotics and antibiotic-associated diarrhea, this is your typical dose. This is the Florastor, that's the Saccharomyces. And here's the safety profile I was looking for, where AHRQ really took a peek and does appear to be quite safe. I tell people to start the probiotics, as they start their antibiotics, and then continue for at least a week to a month after. I'm going to skip this because I know we're getting low on time, and we're going to go to frailty. So frailty, you all are probably as well-versed as I am in terms of its definition, the idea of folks moving slowly, having sarcopenia. And so what can we do to be helpful from an integrative or lifestyle perspective? And that's where we're thinking about interventions to improve muscle strength, muscle mass, coordination, balance. Obviously, the stakes being aging and inflammation, and then the exercise recommendations. These are 4 that my colleague, integrative geriatrician, Dr. Kogan, recommends with evidence. So there's Tai Chi. The nutrition, sometimes you can think about an increased protein intake. You want to be smart about this if you have folks with any CKD, but it may be helpful for opposing sarcopenia. No real evidence that we should be giving estrogen, testosterone for any of this. There is some evidence for fish oil, and there is some evidence for an anti-inflammatory diet where it could have effects on frailty over time. And we've already talked about this. The one thing that you do see in the Mediterranean diet is talk about wine sometimes. And I think that's the one thing that I don't necessarily talk about with folks introducing unless they're already drinking it. The mechanisms of protection, really, Dr. Archer talked about this. The only added things I'll point out is that there is some decent bench science to talk about short chain fatty acids, for instance, which are really helpful for gut health. We know that those are increased with better bacterial. We also get this decreased macrophage marker, which may mean that, the cholesterol piece is better. And so these are just salutary as lab data that help us feel comfortable in the mechanisms. And then the last dietary supplement to just comment around wellness side is vitamin D. There is some evidence for correcting those who are low. The problem is vitamin D has no patents out it, and so there's not a lot of financial interest in really showing people who are low in vitamin D in a serum, correcting it and seeing what their clinical outcomes are. Just don't know that money will ever materialize because you would need very high end and a very expensive study. The other thing to think about with wellness is, should we be considering probiotics in all people for wellness? It certainly is something to consider. We know that most traditional food systems have probiotics in them, whether we're talking about kefir or when people drank raw milk, or when, not suggesting go back to that, but just to say that was in our food stuff. And it's not so much now because of pasteurization. So we may need to just think about how do we correct that. So that brings us to the conclusion that, I think integrative medicine, along with palliative, has this important evidence-informed approach to wellness. And we can think about it in terms of the wheel that Dr. Archer showed from the VA hospital. And we can think about then, well, what are some dietary supplements like probiotics and vitamin D to optimize? We can think about it in the context of nutrition, exercise, all the things that can be helpful, both to prevent risk of frailty, but also in the context of chronic illness, one way or the other. And then there is these specific supplements that have evidence for conditions relevant to our elders: probiotics, vitamin D, and ginkgo St. John's wort, and then the lavender oil. And these are the tools, incidentally, I mentioned consumerlab.com. They test products on the market. It's a prescription database, but it's really helpful. Natural medicine database used to be in the Levy library. For those of you at Mount Sinai, they took it out. It's expensive, but if you can elbow your local librarian to get it back, I think it's super helpful. PubMed obviously has the research as well. This is the academic consortium of which Mount Sinai is a member of, that also has resources. Yeah, also. Sorry. Okay. That's the end. We wanted to leave some time for questions.
Thank you so much for that talk. We have a few questions in the chat. I think the first I'll ask is, how do patients or providers get their patients access to MSBR or MBSR, sorry?
I'll give that to Dr. Archer.
Yeah, that's a great question. I think the first thing that I would do is just take a look online and just see. I think there are a variety of different programs. I would say that Brown and University of Massachusetts on the East Coast are two places that do a lot of training of folks and also offer a number of MBSR courses online. And that's the place that I would start with regard to finding MBSR for patients.
Have you guys found that that's been relatively easy to get people connected, or is that the case?
I find it challenging. I think, and I needed what I will say is, again, a little bit different than thinking about finding a cardiologist or some other specialty. It requires a little digging on my part and networking. And then, of course, keeping that up and seeing who's active and not. So some of it is just legwork.
Gotcha. Okay.
The other thing I would say is that MBSR is just one version, but there are a variety of different ways to introduce mindfulness-based techniques, or even just a frame shift for patients, whether it's acceptance and commitment therapy. And there are just a variety of different approaches to mindfulness that you can introduce to your patients. So while I don't necessarily send all my patients to MBSR courses, I do talk to them about the relationship that they have with their thoughts, which I think is important.
We also have a question asking about, just in your clinic, do you have handouts with the dietary recommendations that you kind of physically give to patients, since it's a lot of information potentially for people?
Yeah, and I can comment on that. And Dr. Archer, if you have something else, some resources as well. What I do is, we have Epic at IFH, just like at Sinai. And so everything is embedded in smart phrases. So I try to populate the after visit summary in a very specific way. So if I'm going to suggest ginkgo, then I'm going to be really specific about the Nature's Way product as an example. If I'm going to suggest the anti-inflammatory diet, it's long, it's a solid paragraph. And so, but I have that embedded. And so it's relatively quick to give the information. I think then the challenge is to help people feel comfortable with not overwhelmed, et cetera.
Yeah, I do the same thing.
We also have a question asking about any thoughts on battlefield acupuncture.
I mean, the simple answer is yes, meaning that battlefield acupuncture has evidence in specific circumstances. I don't know it well enough. And so, the other thing that has some evidence at times is ear acupuncture, ear seeds. And so some acupuncturists will even use ear seeds and have people walk home with them and keep them in for 2 or 3 days as part of their therapies. So yes, it has evidence. I think it has some of the strongest evidence around anxiety and sort of emotional stuff. But I would have to look.
Well, thank you guys so much. We really appreciate your time.
Yeah, thanks so much. Thanks for having us.